Hello everyone. So this video is regarding the Q&A session for online Optom learning series session 2, which was on the practical binocular vision tips in retail setup by Mr. Azam NH Azmi. The questions which were not answered during the session due to lack of time have been answered here.
Okay, hello everybody. Glad to be back again. So the purpose of this video is basically to discuss the questions that has been asked during my presentation last time around. So I'm going to try to address all the questions, and then you can follow me as well as commented on the answers as well in the comment section down below here. All right. So let's address the first question. I think the several questions has been answered, by the way, but just for those who have some interruption during the session, maybe we can actually repeat back again lah. So the first question is coming from Ritik Gurnani. I'm sorry to interrupt, but won't it be correct to actually alleviate the system, which will eventually result in alleviating the symptoms? Okay. The context of our discussion last time around was we want to actually try to incorporate binocular vision clinics and practices into a retail setup. So in the retail setup is going to be slightly different than the clinical based setup. So yes, you are right. If we are elevating the system, definitely the symptom will be going away. However, in the we have to take the perspective of a patient. So basically in retail setup, what we want is to solve their problems first and foremost. Whatever the symptoms that are being faced by the patients, we need to address the symptom first. So for me, in the retail setup, it is much more practical for you to actually try to alleviate and solve the symptom first. After that, once the patient is happy with the treatment and management that you provide to them, you have to actually convince and get the patient to come back to the practice for the treatment and management of the system itself through vision therapy. Okay, so that must be emphasized all the way during the consultation period with the patient, that only vision therapy can actually improve the system. Whatever that you are prescribing, whether it's going to be added lenses or prisms, is meant to alleviate the symptom temporarily. And the added lenses and prisms is meant to be worn only for a short period of time to alleviate the symptom, but not going to improve the system of the patient. Whatever system that you want to manage, accommodation or virgins, need to still to be done and conducted after the symptom has been alleviated. That will make the management of the case much easier, and that it will help also in getting and keeping the motivation of the patient intact throughout the process of managing the patient. So I hope I'm answering the questions from Ritik Gurnani. Second question coming from Jayadip Ravulapati. Won't the patient feel frightened when we say about their condition? Then how to manage them, sir? Right. So basically, yes, everybody who has been told that they have a certain condition, whether it's going to be optometrically or even in medical situation, of course there are going to be some restless situation. It is, in a way, is good that they have some restless situation, so that they are aware that the condition can actually get worse and get to the level where it is much difficult to be controlled and contained. So what I will usually do in the retail and in a setup is I'm going to tell them that because we are talking about a non-strabismus binocular vision disorders, which is a latent condition. So it's not that bad to have the situation and condition, all right? it's not going to cause any impact significantly to their daily activities. Maybe some symptoms will be arise from the condition. However, the system can be improved significantly by the management through vision therapy. That's the key things that you need to emphasize to the patient, that the system, the versions and accommodation can significantly be improved through vision therapy, and then the things are not going to recur if they follow and comply to the vision therapy session that you plan for them. So to answer the question, yes, definitely. However, you need to emphasize that this non-strabismic binocular vision condition is not terrible. It's still manageable. It can get better. So prognosis is very good through many researchers. Through vision therapy, vergence and accommodation, non-strabismic binocular vision disorders are easily being treated, provided that the patient comply with whatever plan of vision therapy and management route that you choose to do on a patient. So I again hope that I am answering your questions, Jayadip. The next question coming from James: can VT increase functional reserve of a person? Yes, that's the purpose of VT first and foremost. The vision therapy is meant to improve the vergence as well as accommodation system at the same time. So whatever that you want to do, you can actually achieve it through vision therapy. However, you have to keep in mind that doing near vision therapy accommodation as well as near NFV and near PFV therapy training is much more workable compared to the distance vergence therapy. So the period or the duration of vision therapy might differ from one vergence system to the other vergence system. So to answer James' questions, yes, it can definitely, but it very much depending on the compliance as well as the type of conditions that the patient is having. Okay, the next question is coming from Jatin Kumar to everyone. Right, sir, if a patient coming to me at retail outlet with a complaint of headaches and watering, after diagnosis we find he or she is suffering from exophoria. So what is a treatment for him or her at optical outlet? Alright, so if in this case you have first symptoms is headaches and watery. Okay, so headaches and watery eyes. I will ask further. I want to know more about the headaches and watery. Is it affecting their daily activity life? Quality of life is being impacted or not? That's the first things that I want to look at. If let's say the quality of life is mildly affected, means that it borders but it's not as bad, they still can cope with that, then definitely for exophoria condition, vision therapy is the first route of treatment for this patient. However, if the condition leading to the symptoms leads to the other problems such as difficulty in sustaining and maintaining near vision for prolonged period of time. So for example, a 25 years old supposed to be able to sustain their convergence and accommodation system for more than 30-45 minutes without any break and without any symptoms, that is normal. However, if they can't or unable to do that, after even 10 to 15 minutes the symptoms starts to arrive, that will be considered as a severe symptoms already. Now the intervention need to be done quickly to solve and relieve the symptoms. So what I will do in more severe symptoms is to try to figure out whether or not prisms can be utilized or added minus lenses can be utilized to actually promote convergence, and then try to actually overcome the situation by promoting the convergence through the negative lenses, added negative lenses, or prism based in to alleviate the symptoms. So very much depending on what type of condition that your patient is facing. If let's say convergence insufficiency, if the symptom is moderate or towards mild perhaps, then you may want to straight away start with the vision therapy. if let's say the symptom is much more severe, all right, and the patient cannot tolerate the symptoms as well as it start to affect their daily activities, then you might want to consider prescribing prisms based in. If the condition is divergence excess exophoria or basic exophoria, then the same approach should be applicable. But for divergence excess exophoria, you can actually utilize added negative lenses for the patient to try to promote convergence at distance, hence reducing the magnitude and prevalence of the exophoria at distance. So that's what I will do in the retail setup for a patient. The second one is Yong. Hi sir, you did not mention about NRA and PRA in accommodative assessment. Are these tests essential for accommodative testing? So the reason the test, to answer your question, yes, the test is still essential and and is also important in assessing accommodative function as well as indirectly testing for the divergence function. However, the context of our discussion again today is for the retail practice. Retail practice, we must remember chair time or the time spent by a patient, a client in the practice is very valuable. You want to spend not too long because you may have a coming in patient, walking in patient into your practice that you want to also being examined, want to examine as well. So that's why I try to actually figure out the best and a test possible that can give you almost every information that you require to make a proper diagnosis of the non-strabismic binocular vision disorders. So in the retail setup, NRA and PRA testing is a bit redundant because it can be represented by your BAF as well as by your MEM retinoscopy or any other dynamic retinoscopy techniques that will also give you the similar findings and similar idea of what is the state of accommodation as well as what is the state of divergence system indirectly. So yes, it is essential still if you are practicing and you have the privilege of time to actually conduct the test. However, I'm talking about the context of retail practice. It is more practical for you to be testing the and conducting the test that is giving you the enough information to make a proper diagnosis and plan for the proper management as well, right? Next question is coming from Asmita. Working in a retail setup and yet working in pediatric population is quite challenging, provided you have a time constraint factor too. How do you work with pediatric population on the same setting? I did mention during the Q&A session in my presentation before that when it comes to pediatric patient, usually in retail setup, as I mentioned and while answering Yong's question just now, is you don't have a privilege of time to spend so long to examine a patient because you are going to have an incoming and walking in patient maybe consistently, unless you work in the retail setup where you dedicate a slot or in a day or even a day itself for a pediatric cases that comes through the appointment. Then that is a different story. That is one of the things that I try to implement and try to get my students basically to maybe have a specialty days for your practice. For example, one day for specialty contact lenses, one day for binocular vision, one day for pediatrics, something like that. But I know it is challenging, it's not easy. So to talk about reality, then it is more difficult to do that, okay, because you don't want to reject somebody who are walking into your patient, because all those are source of income and money for you, for your practice. So what I will usually do practically is to actually segregate the test into several sections. What are the important information that I want to know first in the pediatric population? First and foremost is visual acuity, very critical and very important. Visual function to the highest is visual acuity. So visual acuity level as well as the type and the level of refractive error must be made known first. So I'll be focusing these two components of vision first in the first visit. So I might spend the whole 30 minutes or 45 minutes focusing on these two, and quickly maybe looking at the eye alignment through Hirschberg or quick cover test, okay, and then a quick Bruckner test as Professor Bruce Moore mentioned as well, to establish several states of binocularity and ocular health that will serve as a guide whether or not the patient required to come back for the next visit immediately, or maybe you can actually wait a bit longer to make a second visit for you to complete the assessment of the kids. So I will segregate it into several sessions. Maybe the first session I will focus on the refractive error and visual acuity, and then the second session I will be focusing on the eye alignment and vergence system as well as accommodation system. And then if let's say the third session, maybe I'll be focusing on the ocular health aspect of the kids. So very much depending on what is the problems that you see initially, or what is the symptoms reported by the parents initially, and then you plan the examination into several sessions so that you can actually have more focused tests on a patient. So you have to prioritize what are the information that you want to gain and obtain from the patient for you to plan a proper management for the patient. So to answer Asmita's question, yes, it is challenging. That's why you have to modify your session of your examination session accordingly, according to the needs, requirement and the importance of the test to the patient. After all, the one that we want to focus is the well-being of the patient. Okay, if they have a problems with vision, then address that first. Okay, if the problem is vision and maybe some misalignment of the eyes, address the vision first, because the misalignment of the eyes cannot be addressed and managed if the vision is not perfect yet. So you need to focus. You have to have a focus in your assessment plan and management plan. Okay. The next question is coming from Payal Sanggani. Alright, is virtual reality based VT can cause more functional convergence demand? Functional or convergence demand? From my little experience on VR, because I'm not really keen on using VR as part of the VT session yet, because I know that there are ongoing researches that are being conducted now to see the efficacy of VR in training the vergence as well as accommodation system. So until I have enough evidence that can say that VR will work indefinitely in managing patient with vergence or accommodative disorder, I will reserve my opinion on VR. However, based on my little experience, there are some concern about the change of vergence system as well as accommodation system with use of VR. So what we did in our research was looking at the effect of accommodation as well as vergence function after 30 minutes of VR usage, and then we saw there are statistically significant change in terms of vergence and accommodation system after 30 minutes use of VR. However, clinically it might not be significant, so maybe a prolonged and more longitudinal research need to be done, and I know there are some researchers are conducting this kind of research. So up until then, I reserve my opinion on the use of VR in VT until there is enough evidence to support the use of VR in vision therapy. And then the second question from Ritik Gurnani: is it ever possible to have high PAV for both distance and near and all other investigation leading toward higher convergence finding, yet the patient is having exo deviation? And if it is possible in real life, do optometrists have any role in this condition? So she's talking about the NFV findings, PAV findings. but still the patient is having axo deviation. To tell you the truth, I never seen one, but there is never an impossible things that we can actually see in our clinical practices. So I won't discount the possibilities. It is still possible for the patient to have perfectly normal positive functional versions, or maybe higher than normal positive functional versions, but still the patient have axo deviation. Maybe the additional investigation that I would suggest is to actually look at the glasses and spectacles itself. Sometimes the spectacles and glasses are off from the fitting requirement. For example, the optical center is not really at the center of the pupil. It's going to be going slightly inwards or outwards, and in myopic or hyperopic, it can actually induce some prism. So that prism during examination can actually leads to the perception of presence of axo deviation. So there is a possibilities to have that as well. So but to tell you the truth, I never encountered this kind of type of patient. Usually if axo, they will either have lower PFV, and if let's say they still have an axo and normal or higher than normal PFV, usually they comes with no symptoms. So to answer your question, do optometrists have any role in this condition? Yes, if the symptoms arise from the condition. If there is no symptoms, leave it alone. Okay, leave it alone. You don't have to do anything. It's not an obligation for you to manage the patient without the symptoms, with the sign of with the clinical findings is normal, except for the exophoria. So I hope I answer your questions well. Next question from Rupali Gala. Hello sir, thank you for your valuable insight about the subject. I want to know if you suggest the computer-based home vision therapy to a patient. So for computer-based vision therapy, I do recommend computer-based home vision therapy if the patient can able to afford the cost for the home vision therapy itself. I know the cost is getting cheaper. We have a lot of technologies now with the tablets, phones, then laptop, and so on and so forth. If you can bring down the cost to the patient, and then you can ask the patient to buy and purchase the software to be installed in their iPad, tablets, or even their laptop and computers, then fine, perfectly good. Okay, so it is easier for you to actually monitor, because in the software you have the log, how much and how many vision therapy is and are being conducted by the patient, and then when the patient come back, you can ask them to print out the log, and then you can actually monitor and observe from the log, and then see whether there is a compliance or not. Yes, definitely, if you can actually convince your patients to actually purchase the software and being installed into their computers or tablet or whatever they have, then good, perfect. It's a good thing, because you have multiple advantages doing that. All right. Just why pen to nose therapy is your least favorite VT? Yes, I keep on repeating this point to my students as well, because pen to nose PTN therapy is my least favorite, because most of the time the practitioners is prescribing the PTN wrongly. It means that usually we consider PTN to be done with one perceived target like this. So you are doing this repeatedly, alright, maybe 20-25 cycles in a session, with the purpose of improving the convergence. But the problem of doing this is you don't have the suppression check, because you may also ask the patient to do this, and then they feel that they are doing it correctly, but the fact is there is a suppression of one of the eyes while doing the therapy. So that's why the PTN is not the best and the ideal vision therapy that you want to do on a patient. If ever you want to do the pen to nose, or you want to prescribe a pen to nose to your patient, it should be done with the two targets. One at you hold at 50 centimeters at the arm length position, and the other one is the one that you move, and then the patient must be maintained the physiological diplopia along the way while doing the vision therapy. That is much better. Okay, the second reason of why I'm not in preference of prescribing PTN to my patient is because it can also trigger the accommodation system as well, and then I don't want to disrupt the accommodation system too much while doing the vision therapy. So that's why, because the focus now is to solve Virgin's problem, not the accommodation problem. So that's why my personal preference is not PTN, but I would rather go for broad string or even dot cut in that matters, right? Okay, James again, is there any difference in management for true divergence access and pseudo divergence access, or simulated, I would say, not pseudo, simulated divergence access exophoria? This is actually another topic under intermittent exotropia. Yes, the management is different. Okay, they're very much depending on the type of the intermittent divergence access exotropia, whether it's going to be true or simulated. The management is definitely a different. The different is the management. That's why we want to establish what is the type of intermittent divergence access exotropia that your patient is facing, whether it's a true type or simulated type. Then the management will be different between these two. Navneet Sharma, in vision therapy treatment, at what time we should recommend the home VT along with office-based VT? At what time? I understand from the questions that being asked is maybe Navneet wants to know whether or not the therapy is best to be done in the morning, afternoon, evening, or maybe night for home therapy especially. If you look at the research, there's no time or optimum time that is being recommended to do vision therapy, but as long as you do the vision therapy, it's good enough. But personally, if you want the patient to have a good motivation, and then you want the patient to actually able to comply to the type of vision therapy that you want to perform, I would recommend the therapy to be conducted in the morning, okay, before they start up with all the tasks, the visual tasks, the intensive visual tasks that they're facing for the day. So I will recommend the therapy to be done in the morning, so that the eye is much fresher, and then the patient is much more motivated then, because the eye is still fresh, and then the compliance rate may increase. That is my opinion, by the way. But if you ask about literature or researchers that is saying that morning vision therapy is much better than evening vision therapy, I don't have that. As far as I'm concerned, there's no research conducted to prove otherwise. Okay, so I hope that answer and your questions in your context. That's what I understand from your questions. Okay, James again, the third question. Relieving prism and prism therapy is one to relieve symptoms and one to exercise. How do we decide the amount of prism for prism therapy? Okay, what we talked about before in my presentation was about the relieving prism. We are using the Schurz criterion and Percival's criterion to initially determine the amount and magnitude of prism that we want to prescribe to a patient. That is called a relieving prism. Prism therapy is being prescribed usually to force the eyes to do the versions that is opposite to the problems that they have. For example, if they have exophoria here, so what we usually correct and treat the exotropia using prism base in, okay, to bring the image to the foveal position, right? That is known as relieving prism. However, if you want to train the eyes to do convergence, you need to actually prescribe base out prism. So base out prism, how much and how to decide on the amount of base out prism for exo cases to be prescribed? There's no specific way to determine the amount of base out prism to be prescribed. You have to trial frame first in the clinic. In the clinic, you have to trial frame first. Usually, I will use the indicator from the prism flipper training. Prism flipper training. So from the prism flipper, the maximum amount of prisms that can be tolerated during the prism flipper training is going to be my base of prism that I will be prescribing for prism therapy. So for example, patient can complete 20 cycles of prism flipper therapy in the clinic. So that 8 prism means that 8 prism diopters on the right eye and 8 prism diopter of base out on the left eye. So you have 16 base out prism diopters. So I'm going to use that as a baseline. I'm going to half the value from that, okay, and I'm going to trial frame the 8 prism diopters base out onto the patients, and then ask the patient to actually wear the 8 prism diopters, and then we'll check with the fixation disparity to make sure that the stability of the binocularity is still intact. If it is not, then I will reduce the prisms gradually, 1 prism diopter for each eye at one time, up until the fixation disparity is stabilized. It means that binocularity is still intact, and then I will ask the patient to walk around, do some visual tasks, and then if the patient comfortable with that, then the final prism will be prescribed based on the combination of the vision therapy that you conduct in the clinic, your fixation disparity results, and your trial frame results. So from all these 3 procedures, I will come up with the final prism therapy prisms for the patient to be prescribed, to be worn, usually to be worn during an additional vision therapy, not to be worn while doing tasks, but to be worn during vision therapy at home. All right. Next one, Azim Usmani. What we can do to evaluate binocular vision at optical outlet, as there we don't take there a lot of time. So that's why the purpose of and the context of today's discussion and the previous presentation by me is to try as best as you can to incorporate the best that you can in the retail setup. What can you do, how quick you can actually do the test, and then what are the important tests that you have to do to make up and to come up with the diagnosis. You start slow, it's okay. As long as you start somewhere, you are going to get there. Alright, so for example, after refraction, the common assessment for accommodation and divergence system to be done and tested is accommodation amplitude as well as cover test or Fourier determination. These are the 2 tests that is key and important for you to test. Based on these tests only, you plan what are the other tests that is required to be conducted, all right, to come up with the proper binocular vision diagnosis. So I know it's not going to be easy because retail practice is much more busy, and then you have a limited time as well with the patient to be spent on, but that's why we are having this kind of conversation to try to incorporate some sort of binocular vision testing that is easy to be done, practical, quick, that you can incorporate to your normal routine eye examination, and can also give you the proper findings that can help you to make a diagnosis of binocular vision. Okay, Ritik Gunani again. A person doing continuous near work for maybe 2 to 3 hours and then having eye strain, fatigue and headache, do we have any solution which can relieve these symptoms like in a couple of minutes? Okay, so if let's say this is typical condition for convergence excess, convergence insufficiency, accommodation excess and accommodation insufficiency problems. Typical symptom for those who have this problem. And then if let's say you want to overcome you want the patient to overcome his or her symptoms immediately, usually what I will do first is to ask them to do some visual hygiene. The 20-20-20 rules is a good idea and good starting point to assess whether or not the symptoms can be alleviated by taking a frequent break from the near task, right? So you are talking about 2 to 3 hours continuous near task. That is not healthy first and foremost. Maybe you can advise to the patient that the 20-20-20 rules can be applied here. Right, so every 20 minutes, ask the patient to look 20 feet away for 20 seconds. The purpose is just to relax the convergence and accommodation system intermittently, so that they can come back slightly more fresh when continuing with the near task. And try to modify the 20-20-20 based and according to the patient's jobs requirement as well, because you can't really having a break quite frequent as 20 minutes. You have to understand that as well. So discuss with the patient. If possible, yes, you follow the 20-20-20 rules. If you can't, then you have to modify it. Usually what I will do is every 30 minutes just take 1 minute breaks by walking away from the task and come back and then continue your works. Or if your patient cannot do that, okay, modify it to 1 hour. So you do the task for 1 hour and then take a 5 minutes break by going elsewhere. All right, get away from the task, going elsewhere, make your own coffee, go outside for a while if you have, or you just can close your eyes and relax for a while, take a deep breath, do that for 5 minutes and then come back to the task that you are dealing with. So that will most of the time relieve the symptoms intermittently, right? But the condition is still need to be investigated and then to be identified and managed as well. All right. And next question is coming from WLS. Sir, can we make elderly patient vision system back to normal? Licia. The correct answer, I don't have the correct answer on this. If you talk to conventional optometrists, they will say no, you can't. Definitely, whatever that you do is not going to improve the system at all. However, if you talk to behavioral optometrists, they have a different perspective on the plasticity of the system. So they still believe that the system can still be improved to the certain level, not to the normal or to the perfect level that you want. However, it still can be improved. I tend to actually agree with the perception from the point made by the behavioral optometrist, in which you can still improve the system. But for me, what I would say is the system is improving provided the patient have enough compliance to the whatever that you want to do and motivation to do so as well. These two in elderly patient, especially in presbyopic and pre-presbyopic patient, is key important factors to determine the successful of vision therapy on this elderly patient. So to answer your question, if you believe in behavioral optometrist approach, then you should try to do something about the condition, but sit down and discuss with the patient that most likely it will not work unless the patient have a good motivation on doing that and comply to whatever plan of management that you want to do. And second one, don't over promise to the patient that the system is going to be back to normal. Okay, you don't over promise that, because usually we don't have enough research finding showing that the PFV and FV accommodation function can still be improved in the elderly patient. Accommodation definitely no, but the vision system, can it be improved in elderly patient? We don't have enough research to support that. So don't over promise, just sit down with the patient. It is still possible to improve, but not to the level that the patient or the normal level that the patient is expected to have, right? So very much depending on what you believe in. So if you are conventional optometrist, usually you just want to solve the symptoms, but if you are agree in the approach by the behavioral optometrist, you might want to consider actually trying to improve the system still, even at the age at the elderly age. All right. And the last question is from Jayadip Ravulapati. According you, what is the best and easy VT for psoriasis for both patient and practitioner, sir? If you ask me personally, I would say broad string. Full stop. Broad string has it is a wonders of vision therapy for vision system, for psoriasis in particular. Okay, because it can do several things. You can actually do anti-suppression therapy with it. You can do convergence therapy. You can do divergence therapy. You can do therapy for vergence system at different position of gaze. You can monitor several things. For example, the silo, the small in large out effect from vision therapy. You can notice there are going to be some kinesthetic effect as well during the vision therapy that the patient can report to, and it's quite practically easy as well for the patient to be to conduct and to perform the broad string therapy in the office. So if you ask me personally, I would say broad string as my personal favorite for many reasons, and I would encourage many practitioners out there to also explore the wonders of broad string vision therapy in your practice, because having this broad string vision therapy is sufficient actually to conduct your to start off your journey into binocular vision practice for your retail setup or for any kind of setup that you are planning to have. All right, so that's the questions that I received during the presentation last day last time around. So I hope that I have addressed all the questions that you asked. Any questions and any further questions that you probably have, you may want to keep the discussion alive in the comment section down there, or maybe you can actually directly email me if you have any questions that you want a clarification, and we can still have a discussion together as well, because as long as I'm alive and as long as I'm still in this particular field, the interesting field of optometry, I'm still learning as well. Okay, so maybe you have an experience or better experiences than me in dealing with the binocular vision situation. You may want to share with me as well your experience so that we can actually learn together. Right, so on that note, thank you very much again. Thank you organizer for arranging this particular wonderful online learning system. So hopefully everybody can be connected while we are working in a small community, and then maybe in the future we are getting bigger and bigger, and then we can actually share our knowledge, share our experience together so that everybody can learn from each other, right? So kudos to the organizer. Thank you very much. I hope to see you soon. Thank you.